alaikum wa rahmatullah, alhamdulillah, wa sallallahu ala rasulillah. This is Amber Khan, IMANA Education Chair. I hope everyone is doing well. We are back with another education webinar tonight, and we have a very exciting one. This is our first IMANA Education webinar on the topic of podiatry, a much needed topic and one that I'm sure many in our community will benefit from. The theme is foot care for Muslims. And we have several speakers tonight who will discuss foot care considerations during several obligatory rituals, including Salah, wudu, the performance of pilgrimage, as well as during Ramadan. They'll also discuss reasons on why those from South Asia, as well as the Middle East, are uniquely at risk for metabolic syndrome and diabetes, and therefore need greater monitoring and awareness of diabetic foot care. And finally, they will go through basic education on diabetic foot pathophysiology, diabetic foot care education, and tips for prevention of complications. Tonight, we have three podiatrists contributing to tonight's talk. Our first speaker is Dr. Mohammed Junayed Khan. He completed his doctorate of podiatric medicine at Temple University, his surgical residency at Montefiore Mount Vernon Hospital, and research fellowship at Penn Presbyterian at the University of Pennsylvania. He currently works at Neighborhood Health Center of Western New York in Buffalo and is involved in the surgical education of the podiatric surgery residents of Catholic Health System, and one that the IMANA community may know of as he does establish podiatric medical and surgical mission trips abroad with IMANA. Our second speaker is Dr. Jacob Nasser, who also completed his podiatric medical education at Temple. He graduated as chief at Bridgeport Hospital, Yale, New Haven Health Residency, and he just recently completed his training this past June 2023. So congratulations to you, Dr. Nasser. He plans to become part of the first fellowship program in Canada to teach future generations and his colleagues to spread the knowledge of podiatry across the country. And finally, last but not least, we have Dr. Rafay Qureshi. He also completed his podiatric medical school at Temple and his surgical training at HCA Houston Healthcare Kingwood. He has a keen interest in reconstructive surgery, sports medicine, wound care, and is passionate about using his knowledge and skill set to give back to underdeserved populations. On behalf of IMANA, we would like to thank all three of you for taking the time tonight to prepare for this presentation and to share your expertise with the community. We will, of course, be sharing this recording on our website as well as YouTube channel and share their contact information if in the future you would like to reach out to them. So without further ado, I'm going to go ahead and pass it over to Dr. Mohammed, and you can begin whenever you're ready. Thank you.
All right, Dr. Amber, thank you very much for the wonderful introduction. Again, my name is Dr. Mohammed Junayed Khan. I'm going to start off the talk talking about the etiquettes for competent care for the Muslim patient. Just to quickly run through the objectives. So we're going to be raising awareness and educating lower extremity specialists on religious views of Muslims and how this is going to affect the Muslim patient's perception of care. I'm going to go through some of the treatment approaches that adhere to the belief of Muslim patients. And I'm hoping by the end of this talk, any of the healthcare providers that's in the audience here will be able to be comfortable treating the Muslim patients and have confidence in doing so. So jumping right into it. So what is Islam in a brief nutshell? It's the most recent of the monotheistic Abrahamic faiths. There are 5 pillars of Islam, and I'm going to be actually going into some of these in a little bit more detail. And just kind of jumping into some of the statistics, population statistics. So worldwide, Muslims make up about 2 billion of the world's population, which is the second largest population in the world. In the US, by 2035, Muslims are projected to be the second most populous religious minority in America, actually. And this slide is just showing that Muslims come from all over the world. There's really no such thing as Muslim culture. You may see Muslim patients who are from the Middle East or South Asia or parts of Africa, and they all may have different cultures, right? But in Islam, we have a set of rules or a guideline for a way of life that we all follow. And that's what I'm really going to be focusing on today. You just want to keep those two things distinct. So first, just talking about the modesty and interactions within Islam. So first, I want to talk about the concept called the awra, which is the private part that has to be covered. And this differs depending on who you're around. So it's different whether you're around your spouse, your immediate family members, if you're around someone of the same gender, if you're someone around of the opposite gender. But in the medical setting, a safe assumption that is for a man, the awra, or the private part that should always be covered, is the navel to the knees. For a woman, and this is debated, is the head, the hair, the chest, the body figure, the legs, and the arms. And again, it's, you will see Muslim women dressed from, this entire spectrum that I have listed here. But in general, the more that you cover your awra, and generally accepted, is the more pleasing it is to God. So now, how does this really relate to the private providers in this room who are maybe treating Muslim patients? So if you're a male and you have a female patient who is of the Muslim faith, it's probably not a safe idea to try to shake her hand. Typically, we keep physical touching to be very limited and purposeful, especially for the purposes of the physical exam. You really want to be communicating what you're doing when you're dealing with the Muslim patient. And in podiatry, if we're doing something like a limb length discrepancy assessment, we're not just looking at the feet. We're looking at the ankles, we're looking at the knees, the hips, we may be looking at the chest and the shoulders. So if you're not communicating what you're doing beforehand, the patient may get extremely awkward, right? So always ask for permission, especially before touching the patient, especially if it's within the awra. Oftentimes you'll find that Muslim patients prefer the same gender. So a man may prefer a man, a woman may prefer a woman, just for reasons that I just mentioned. And next, just a brief discussion about animal-derived products and how it relates to podiatric care. Typically, Muslims avoid animal, especially pork-derived gelatinous capsules or tablets, but it is permissible to consume these if you have no reasonable alternatives. If you're in a situation of necessity, it's okay. And I'd say for most prescription medications, I mean, it's really hard to avoid, gelatinous capsules or tablets, because they're almost always animal-derived and sometimes porcine-derived, especially in the US at least. However, if you are recommending tablets or vitamin supplements, you actually can find these with halal certification nowadays. And again, halal means something that's permissible within the boundaries in the Sharia of Islam. And you'll see a halal certification right on it. Now, as this relates to lower extremity care, if we're talking about wound care or elective surgery or outpatient surgery, inpatient surgery, you may be we often use skin substitutes, we use bone grafts, and we use different types of biologics, right? And sometimes these are animal derived. A lot of these are actually porcine or pork derived products. And you as a provider, you should be aware of what you're actually putting onto the patient or putting into the patient. And as the patients, the Muslims in the audience here, you should be informed as to what is going on your body, right? You should be asking about these things. And again, it is permissible to use these in the situation of necessity or no reasonable alternatives. But as someone who is actively using these things regularly, I'd say, a couple times a month, I can confidently say that alternatives almost always exist, right? You have non-animal derived products, you have things from coral, you have things from non-porcine derived alternatives. So yeah, it is permissible in such situations of necessity, but for this specific type of field, whether it's wound care or surgery, in my opinion, I don't really know if it's appropriate, because you almost always have an alternative. Now, changing gears and talking about ablution, or wudu as it's called in Arabic. This is the ritual purification that's required before prayers. The face, the arms, the head, and the feet must be washed. Focusing a little bit on what's happening in the feet here. So the ankle and below have to be totally washed with water. You have to get in between the toes as well here. And we'll talk about why this can be a little problematic if you're not drying off between your toes properly. And during the wudu, the water has to contact the fingernails and the toenails, right? And this can be problematic because some of the topical antifungals that we prescribe in podiatry, they're more of a lacquer, right? They form like a barrier, like a little film over the nail. And if the water is not penetrating through that, then technically, the wudu is not valid. It's the same reason why a lot of Muslim sisters don't wear nail polish, that water is not permeable through, right? So you really have to keep in mind what products you're prescribing to these patients, because if you're prescribing something that's not water soluble, permeable, the patient will know right away and probably not use it, and your compliance will probably be pretty low. Now, fungus is this is called Diabetic, which means fungus of the foot, and this does have a direct relationship with making wudu, or the ablution, as I mentioned. And I'm just going to go through a few studies kind of detailing some of the risk factors and why this happens. So this was one of the original studies that was done by Rabubi et al. In 1998. This study was done in South Africa. They looked at 8 mosques, and they had 2 cohorts. They had a Muslim cohort. They had 78 adult Muslim males, and they had a non-Muslim cohort of 72 non-Muslim males. They took skin and nail scrapings with those that already had clinical signs of fungal infection. And the mosque group had an 85% prevalence of Diabetes, whereas the control group had a 41% prevalence of Diabetes. So this was a statistically significant difference. The conclusions were that Diabetes was more prevalent amongst male Muslim worshippers than age-matched non-Muslim controls. So this was like one of the original studies, and this kind of opened up the gateway for some of the studies I'm going to be talking about in the next few slides. But these authors attributed the higher prevalence of Diabetes amongst Muslims to the use of the communal wudu areas and the prayer carpets of the mosques. And this was, again, from that original study. If you see on the right-hand side here, this is a pretty typical wudu area that you'll find across North America, at least, where you have a wudu area where people sit down right here, and their feet are here, and barefoot, right? And they're walking barefoot across this tile. You have oftentimes a towel. You'll have rubber shoes or Crocs that people are sharing, right? So these are all just like very, very, high risk factors for spreading fungus. And there is data to support this. And this is a pretty typical communal prayer area where you have the carpet, and oftentimes, worshipers are coming in barefoot. And again, we'll talk a little bit more about these down the road, but they gave a few recommendations as to how the Diabetes can be managed. So first, the individual have to be educated on what Diabetes is, right? So this on the right-hand side is an example of a poster that was hanging up within this masjid in South Africa. I'm not a big fan of it because it uses very medical terms like maceration and vesiculation that the layperson may not understand, right? So education is very key. They should know what the signs and symptoms of Diabetes are. They should know what the treatment options are. They should know that this is something that can be treated. This is not just dry skin, right? And they should know how to prevent the spread of infection as well. And some of the things that the authors recommended are, talking about this during the Friday sermons, putting up posters, sending out newsletters, maybe just like once or twice a year, just kind of having this discussion that, hey, this is something that Muslims are more prone to, or they're more at risk for. And the next part of the recommendations they gave for how to manage this is to treat the environment, right? So there are actually antimicrobial carpets that exist, a little bit more for than bacteria than for fungus, but they do exist. And frequent vacuumings of these carpets is also very important as well. There are antifungal carpet shampoos and sprays that can be used. There is some literature showing that jet hosing at least the swimming pools decreases the risk of spreading Diabetes. And I don't see why this can't be done for wudu areas as well, right? And of course, not every masjid has the capability of jet hosing and cleaning the wudu areas, but even just simple regular washing of the wudu floors surely will make a difference. This was a different study done in Turkey. This was a prospective study looking at 14 different mosques. They looked at 461 adult Muslim males. Again, they looked at skin and nail scrapings from those that already had clinical signs of infection. I really like this study because it looked at they did a questionnaire. They looked at demographics, occupational, and specific data related to risk factors. And I'm going to go through them in the next few slides. They found that there was about a 39% prevalence of foot fungus with those that had clinical signs of infection, which is pretty high. And 80% of these, about 80% of these was positive between the web spaces. And T. rubrum was the most common affecting fungal organism, which holds true for the general population as well. Now, going into some of these risk factors, and I thought, some of these statistics were very telling, and these are all statistically significant in this study. But age, so these are the age groups that are at greater risk for tinea pedis. So between basically the ages of 40 to 59, they had a much higher risk of contracting the tinea pedis. And the authors didn't go into why per se, but just in my opinion, just again, this is anecdotal. This is oftentimes the age group that you'll see is frequenting the mosque the most, right? Like they're oftentimes in and out of the masjid the most. They're spending the most time there. So that could be a reason why. But again, this isn't something that they touched on. And this is looking at a wide variety of things. And the ones that I want to point out are in the red stars and the green stars. So anything with the red star puts you at risk for picking up tinea pedis, and anything with the green star is protective against tinea pedis. So if you're making wudu 3 to 5 times a day, if you're never drying your feet, if you're wearing these rubber or these type of shoes that don't breathe very well, and if you're sharing these shoes, then you're at a much higher risk of picking up and contracting and spreading tinea pedis. On the other hand, if you're always drying your feet, especially between your toes, if you're wearing leather soled or soles that are well breathing, they're ventilating well, and if the worshippers are never sharing their shoes, then you're at a much lower risk of contracting the tinea pedis. And this is just something to remind any Muslim patient that you have that has tinea pedis that there's a good likelihood that there's a communal factor to this. So you want to keep these things in mind. And this is just a summary of some of those risk factors. But one thing I wanted to point out is that there is actually no association between educational level, occupational level, and marital status with foot fungus infection, at least in this study. And this is important because, I sometimes see this in Muslim patients, especially, and they'll say, I swear I'm clean. I clean my feet. I don't know why this happens. I make wudu like 18 times a day, and I don't know why this is still happening, right? You have to let them know that it's not about how clean you are. It's not about, your education level. It's not that, there's sometimes a taboo attached to some of these things, but just let them know you just happen to be at the wrong place at the wrong time, and you picked up a fungal infection, right? And you have to get treated. So this is also something important to get across as well. And just to quickly run through some of the educational things we can do. So this on the right-hand side here, I think this is a little bit more a better poster, I guess, of something that should be hanging up in the masjid, where, using layman's terms, if you're having itching and stinging between the toes, if you have cracked skin between the toes, if you have these little blisters forming at the top of the toes, and you have this dry, flaky skin, that these may be signs of athlete's foot or tinea pedis. Things we can do to treat it or prevent it. As I said, dry your feet regularly, wear open-toed shoes or sandals. Don't share those shoes with other people. In my opinion, don't walk barefoot in the masjid, right? Don't use the rubber shoes that are typically sitting around in the wudu areas, right? And don't share any of that stuff, right? And that way, it's you're a little bit less likely to pick up the fungal infection and spread it. And once you're aware of these signs and symptoms, educate your family, educate your relatives, educate your friends that are also going to the mosque. And, you have to make sure you're having these discussions with your Muslim patients, especially because, as I mentioned, there is a communal component to this. Now, changing gears a little bit and talking about Salah or prayer. And you have to be in the purified state, or you have to make wudu prior to the prayer. So, and this is mandatory for 5 times a day. There are additional prayers that are often performed as well. And there are 7 postures during the prayer. I'm going to go through kind of a slide that depicts them, but each of these movements are mandatory as long as you're physically capable. I want to talk about posture 6 here, tashahhud. And this is the seated position where you're sitting on your left foot and your right foot is erect, facing toward the qibla or the direction of prayer. And this is technically recommended, but this can be extremely difficult if you have certain foot conditions. Like, for example, if you have hallux limitus, like pictured here, like really, really bad toe, big toe, first MPJ, arthritis. So you're going to have a hard time doing this position, right? If you have flexor contractures, if you have hammer toes, for example, you may be able to do this position, but with a lot of discomfort, right? And I've actually had patients come in and say, hey, like I can't bend my toe. I need to have surgery. You need to fix my joint. And, at that point I have to tell them that, hey, like, although this is important and there is a reward for doing this, right? This is technically recommended, right? And I don't know if it's worth, putting you through surgery and anesthesia for something that's recommended. So that's something that, you also want to have a discussion with your patients as well. And, in general, arthritis can happen anywhere. It can happen in the low back, it can happen in the knees and the hips. And looking at some of these positions, it's not always going to be possible. So it's totally normal to see Muslim worshipers praying in a seated position, like pictured here, or praying in a wheelchair if you're physically disabled, right? That's totally normal and it's permissible within the boundaries of the religion of Islam. So talking about Ramadan briefly, so Muslims are required to fast from sunrise to sunset for the holy month of Ramadan. So there's no food or water allowed to be consumed. And you're not allowed to have oral medications during the fasting hours as well. Now, topical medications are permissible. You can't have IV fluids. And fasting is technically forbidden if it jeopardizes health and well-being. Now, if you're a provider and you're tuning in, you may have been faced with a situation where, a Muslim patient may or may not want to take a certain medication, antibiotic, whatever, and they may have a serious infection, right? Like it happens all the time. And you have to remind them that, your health and well-being actually supersede, it takes priority over a fast, because you can make up your fast, right? But you may lose your life if you don't take this medication. So just something to kind of think about, because I found that Muslim patients are often, they're very gung-ho about the rituals sometimes, and they're maybe willing to sacrifice their health for it, and they have to know when it's appropriate and when it's not. And just two other bullet points. Ramadan is not an ideal time to schedule outpatient surgery, and if they do have some type of musculoskeletal issue, it wouldn't be a good time to send them to physical therapy, for example. It may be very physically taxing on them. There's a type of prayer called the Tarawih prayer. It's recommended. It's not mandatory, but you'll find that a lot of Muslims do attend this. And this happens during the nighttime, where they're praying up to 20 extra rakat or 20 extra cycles every night. And on average, the average Muslim will be standing for about an hour and a half to 2 hours, right? That's per night. And that's for 30 days straight or 28 days straight. And that's a lot of activity for oftentimes someone who may be elderly, for someone who may be very sedentary, and all of a sudden, they're standing an extra 2 hours every day. So, I'm actually still seeing these patients now, but you have people coming in with Achilles tendonitis, right? People who have flat feet will get tendonitis of their posterior tibial tendon, right? Or heel pain. And so this is just kind of something to keep in mind as well, where if you are practicing in an area where you have a lot of Muslim patients, you may see an up spike in some of these foot-related issues temporarily after Ramadan. Now, to talk about Hajj and Umrah, this is going to be the last major discussion of the rituals we're going through. So Hajj in Arabic is Arabic for pilgrimage, sorry. And this is a requirement for every Muslim to make at least once in their lifetime. And it's a series of rituals performed over a 5 to 7 day span. And I thought this was pretty amazing. I mean, on average, it's about 40 miles of distance traveled on foot over this 5 to 7 day span. And again, these are sometimes elderly people who are very sedentary. Just, all of a sudden they're doing 40 miles in 5 days. So, and there is a lesser pilgrimage called the umrah. This is voluntary. It's not mandatory, and this involves less rituals, and this can be done any time of the year. This is just a satellite image map, I guess, of showing you some of the sites related to the Hajj and how far apart some of these are, right? And there are some people that walk parts of this. So you can see some of these are pretty far away. But nowadays you do have buses where you can go from one place to the other for the most part. I'm not going to go through these in much detail, but there is a part of the ritual of the Hajj called the Tawaf and the Sa'i. These are both part of the Umrah. So if you're doing Umrah, these are the major rituals for the Umrah. The Tawaf is about 1 to 3 miles of walking. The Sa'i is about a little under 2 miles of walking. This is if you're actually walking. I mean, sometimes people are in wheelchairs and you're pushing a relative in a wheelchair. And I actually did this at Umrah with a relative who was in a wheelchair, and I calculated 10 miles for these two things. So, it really depends on where you are in the mosque when you're performing these. So it's something to keep in mind. There is some variability. Now, these are some of this specific ritual, the day of the Jamarat, is this is part of the Hajj only, not the umrah. And you're taking 3 round trips, and from the Mina, which is in the tents here, to this bridge here. And this is 20 miles over 3 round trips, which is that's a lot of walking. It's to do over a 3-day span even. So, and before I get into recommendations for what I would recommend for a Muslim patient going to Hajj, I want to talk about footwear for just a bit. So there is some confusion that exists regarding footwear during the pilgrimages. Typically, when a Muslim enters a masjid, a mosque, they have to take off their shoes and their sandals. They have to be either in their socks, or they have to be barefoot for the most part. And a lot of these rituals during the Hajj or the Umrah are actually performed within Masjid Haram. It's within the holy mosque. So oftentimes Muslim worshippers will take off their shoes and they'll walk barefoot, right? They'll walk barefoot, or they're walking in socks, for example. But you don't necessarily have to, right? That's where some of this confusion comes from. So if you're a female, you can wear socks with closed-toed shoes. You can wear open-toed shoes. You can wear sandals. If you have flat feet and you want to wear sneakers, like women can do that, right? I really think that this is a blessing. This is a rahmah from God, because as you'll see, being female actually is a risk factor for some of these complications I'm going to talk about. For males, it's a little bit more debated, but in general, the medial and lateral malleoli of the ankle have to be uncovered, which is the ankle bones. And then the upper and middle portion, or the tarsal bones pictured here, have to be uncovered. So a safe bet, if you are going to wear some type of footwear during the pilgrimage, is to wear a flip-flop, something like this. And I just wanted to briefly touch on this article here that was performed by the Diabetic Foot Care Research Team in Hajj. And I just wanted to point this out because this entire statement I underlined is actually incorrect. So it said that pilgrims are required to make circuits barefooted on scorching marbles around the holy mosque and march between the hillocks for hours. So, so just as I mentioned, like you don't have to be barefooted, right? And the fact that some of these things are actually published and put out there is perpetuating those confusions, right? So just want to be very clear, they do not have to be barefooted. And scorching marbles, that's also untrue, because anyone who's actually done this barefoot, made the pilgrimage barefoot, will know that the marble is actually very cool and comfortable. And it's actually a very special type of marble called the Thassos marble, imported from Greece, that keeps it cool. So it's, again, this statement is true, and it's very untrue. And I just want to put that out there as I talk about some of these complications that happen during the Hajj. So this study was done in 2021. This was a cross-sectional survey performed during the Hajj season. There was 1,715 pilgrims that were looked at. And these were not pilgrims that were in medical tents. This was in the general population, right? And these were all adults over the age of 18. And they looked at falls. So there was about 13.76% of the patients that were examined here actually experienced falls, which is pretty high in my opinion. And these were obviously excluded from the analysis of musculoskeletal pain, because they fell, obviously they're going to have pain. And anyone over the age of 50 and female were at greater risk for falls, according to this study. And the rest of the pilgrims that were looked at, the 1,479 patients, about 80% of them experienced pain, which is, that's almost everybody, right? And again, musculoskeletal pain was more commonly experienced in females, and about 65.38% of these pilgrims experienced lower limb pain, right? So this is a very pertinent topic. If you're a provider and you have a patient or a Muslim that's going to be going for Hajj or Umrah, like this is very relevant to what we do, right? So these are some of the risk factors, again, for lower limb pain: being female, over the age of 60, and obesity, a BMI over 30. This is just a little pictorial showing you where most of the pilgrims experience their pain, and you'll see that most of the pain actually is in the knee, in the leg, and in the foot and ankle. Foot and ankle being actually the highest of anything. 38.34% of all pilgrims experienced ankle and foot pain. Again, these are some of the risk factors. Again, these are all statistically significant: being over the age of 60 and BMI over 30. This was another study looking at a cohort of 129 pilgrims that were looked at prospectively. So 31.8% of these pilgrims experienced blisters. Again, looking at risk factors, female, overweight, and obesity were all associated with these complications. And this next study in 2020 specifically looked at diabetics, and they found that 70.8% of these diabetics actually had foot injuries. So again, within the diabetics that are performing the Hajj, foot injuries were the most common complication. Second to that were hyperglycemia and then hypoglycemia. Of the foot-related injuries, redness was the most common presenting complication, and then bullets and blisters. One really important point here is that non-compliance was associated with complications in the feet for diabetics. So, these are oftentimes patients who they're not seeing their camp physician if something goes wrong. They're not seeing their medical doctor or their podiatrist before going to Hajj, and 70% of these people aren't even checking their glucose, or they didn't even bring their glucometer, right? So again, non-compliance is definitely related to diabetic foot related complications. So these are just some safety recommendations by some of the authors in the previous studies and some of my own recommendations. You have to wear well-fitting shoes. You have to wear shoes that are already broken in. I feel like everyone I know or I've spoken to said that, they bought a brand new pair of shoes and it's going to be comfortable, or a brand new pair of sandals. Like, that's actually not what you want to do, right? If you do buy a brand new pair of shoes or sandals, you want to break them in beforehand, wear them around the house, because you don't want to be breaking them in while you're doing 40 miles in 5 days, right? For women, it's recommended to wear the socks, right? It's in my opinion, and from a medical standpoint, I understand it's over 100 degrees typically in Saudi Arabia while you're doing the pilgrimage, and it's sweaty, but it does reduce impact on the feet. And wear the supportive sneakers if you have to, right? If you have the flat feet, if you have high arched feet, right, you're definitely going to have more pain if you don't have proper support. So again, if you're a woman, you should take advantage of the fact that you can wear these sneakers, because this is it makes things a lot easier for you, definitely. And if you're a man, same thing. If you have flat feet, you can wear there are many sandals with arch support out there now that you could wear. It's important to moisturize your feet, right? This is going to reduce some of the friction while you're walking. And a really, really key point here, and I have a picture of people doing a marathon, is that you have to think about this as if this is a marathon, right? If you have a Muslim patient and they tell you they're going for Hajj this year, they're going for umrah, let them know that, hey, like, this is going to be a marathon. Slowly ramp up your activity level, right? You have to start training for it. If you can lose some weight before it, you're going to have less complications, right? We just talked about BMI. So this is kind of the approach we need to have if we come across a Muslim patient who tells you that they're going for the pilgrimage. And it's really important, especially if you're diabetic, to seek medical and podiatric consultation before, during, and after the Hajj. It's very, very important. I can't stress that enough. So some of the take-home points, Islam is the fastest growing religion in the world and in the USA. So, it is a very high likelihood that you're going to be seeing a Muslim patient in your office at some point or the other. So it's important to kind of keep some of these things about modesty and animal-derived products in mind that I mentioned. Muslims are at greater risk for fungal infections of the feet. And it's simply not enough to just treat the medication. You kind of have to keep those communal factors in mind that I talked about to prevent the recurrence, because, you can treat the fungus, but if they're going to the mosque and walking barefoot again, then, sharing shoes in the wudu area, they're probably going to pick it up again, right? And for Hajj, as I just mentioned, training and preparation is key, right? It's like a marathon. You have to train for it. You have to lead up, slowly increase that activity. And, I think one of the key things that I took away from this whole thing, at least from my personal education, is that flexibility Islam is very flexible when it comes to medical care, right? Your health and well-being are more important than any of those things that I said are mandatory or recommended, right? If it really means that your health and well-being are going to suffer, or if your foot or your life is at risk, right, then your health and well-being comes before all of that stuff, basically. So that's basically it from my standpoint. I'm going to hand it over to Dr. Nasser now.
No, I'll go ahead and start this first part, actually. Okay, assalamu alaikum, everyone. My name is Rafay Qureshi, and for this second PowerPoint and second part of this webinar, me and Dr. Nasser will be discussing two different topics: the unique risks for different Muslim majority populations in developing diabetes and metabolic syndrome, as well as touching on some pathophysiology, diabetic foot care, education, and prevention of complications of the diabetic foot. So the objectives of this talk will be to highlight specific risk factors for diabetes and metabolic syndrome among Muslim patients, especially those from Muslim majority nations living in the United States. We'll also be reflecting on lessons from the Prophet Muhammad, peace be upon him, on diet, exercise, moderation, and healthy habits. We'll also be presenting a brief overview on diabetic foot pathophysiology, as well as education on the diabetic foot care and prevention of complications. So to start off, we'll talk about a few definitions. So diabetes is defined as a disease in which the body's ability to produce or respond to insulin is impaired, resulting in an abnormal metabolism of carbs and elevated levels of glucose in the blood and urine. It's broken down into two types, type 1 and type 2, and this talk will focus more so on type 2 diabetes. Metabolic syndrome is a group of conditions that raise a risk of developing a collection of diseases such as heart disease, diabetes, and stroke. And it's classified when you have 3 of the 5 following conditions, including high blood glucose, low HDLs, high triglycerides, large waist circumference, and high blood pressure. So several factors of consideration when evaluating, especially patients of Muslim majority nations, are genetic predisposition, obesity rates, lifestyle and dietary habits, socioeconomic factors, and urbanization and industrialization, which we'll go over in some details shortly. So when it comes to genetic predisposition, there's some ethnic groups that have a higher prevalence of genetic variants that are associated with insulin resistance, as well as low production of beta cells, which lead to impaired glucose metabolism. Therefore, these populations have a greater likelihood of developing diabetes. And for the purpose of this talk, these specific populations that we'll be going over are South Asians, Arabs, and North Africans, which are a large portion of the Muslim majority populations that are here in the United States. It's also important to note that genetic factors alone do not determine an individual's risk solely, but can also be modulated by lifestyle choices. But these implications must not be ignored and still be taken into consideration. Here's a study that I found, and I wanted to go over understanding and going over the high prevalence of diabetes that's been recorded in South Asians living in the United States compared with 4 different racial and ethnic groups. So this studies in diabetes care in 2014 compared the South Asian population with 4 other ethnic groups in the United States to determine sociodemographic, lifestyle, or metabolic factors that could explain higher diabetes prevalence and whether beta cell dysfunction or insulin resistance occurred at younger ages. So this was a study that included approximately 10,000 different people, and they concluded that South Asians have a significantly higher age-adjusted rate of diabetes at 23% versus other ethnic groups, which the percentages are listed here. And the difference in diabetes with South Asians versus other ethnic groups increased further after adjusting for potential confounders, which means that there is a higher prevalence of diabetes that is not explained by traditional factors and may be due to some genetic predisposition in this population. And South Asians may have a lower beta cell function, which beta cells function to secrete insulin, as well as an inability to compensate for higher blood sugar levels due to insulin resistance. And here are a couple of charts from this study showing the comparison between South Asian populations and having a higher rate of insulin resistance, and another graph showing the decreased level of beta cell activity in this population compared to other ethnic groups. Obesity is also a significant risk factor for metabolic syndrome and diabetes, and some populations, especially those from the Muslim majority populations here in the United States, may have a higher rate of obesity due to different combination of factors. There's some studies that show that 5 out of the top 15 most obese countries in the world are part of the geographical location of the Middle East and North Africa. And South Asians specifically have some of the largest waist circumference rates and measurements across the world. Unfortunately, with these populations in the Middle East and South Asia, Exercise, unfortunately, is not a defining part of the culture. And it's also noted that women have an increased likelihood of being overweight and obese in these populations, which can be partially attributed due to cultural norms, in which women in a lot of these cultures are not as outgoing and stay at home mostly. And this is not due to any religious reason, but it's more due to the cultural norms of that part of the world. And here's just a graph that shows the exponential increase in rates of obesity in Middle East and North African nations from the 1970s to 2020. So lifestyle and dietary habits also play a very important role in developing diabetes, aside from the non-controllable factors such as genetics. Certain dietary patterns and lifestyle choices can attribute to development of diabetes, such as consumption of calorie-dense food, excessive sugar intake, a sedentary lifestyle, and lack of physical activity. These habits are not specific to Muslim majority populations, as it's very prevalent here in the West as well, but these can confound when you're genetically predisposed to developing diabetes. These can exacerbate them and increase the overall rates in certain populations that may be more inclined to develop these conditions. So South Asian, Middle Eastern diets often consist of very carb-heavy foods, such as rice, flatbreads, fried snacks with excessive oils and salts, and sugary sweets and drinks. All of these images here are of food that are very, very delicious, but unfortunately with a lot of our communities, we don't really have a balanced meal. We don't take into consideration balancing our carbs with proteins, with fruits and vegetables. And oftentimes when we eat until our bellies are bloated and are full, which is actually not recommended in our religion, which we'll go over. And other socioeconomic factors also can contribute to diabetes being prevalent in Muslim majority populations, such as limited access to healthcare, education, and resources, especially back in the Middle East, North Africa, and South Asia, as well as disparities in healthcare infrastructure and just general neglect for our overall well-being. Here's a study that compares the adult Arabic population with the Jewish population in Israel, and they concluded that the Arabic population has a higher risk of diabetes than the Jewish population does in Israel. This was a population study done from 2007 to 2011, looking at a 4-year incidence of diabetes hazard ratios that were adjusted for sex and metabolic syndrome components. And the results showed that the adjusted diabetes prevalence rates were 18.4% for the Arabic population and 10.3% among the Jewish population. And their conclusions were that there was much higher rates of diabetes among the Arabic population in Israel versus the Jewish population. But it's also important to note that the study is flawed to an extent because the Arabic population in Israel has a lower socioeconomic status and poor healthcare or poor health awareness than their counterparts do, and their access to health infrastructure is unequal. Urbanization and industrialization also can lead to people developing diabetes and metabolic syndrome. These are not specific to Muslim majority populations, as it's applicable here in the West as well. But increased use of cars and lack of walking, lack of exercise, decreased physical activity, and increased consumption of processed foods and sedentary work environments, which are prevalent here in the West, as well as in certain Gulf states in the Middle East, also contribute to these higher rates as we see in these patients. I want to go over some lessons from the Prophet, peace be upon him, and the Quran on diet and moderation that we should definitely remind these patients in our communities because these are recommendations coming straight from the hadith and life of the Prophet ﷺ, as well as our holy book of the Quran. The Prophet, peace be upon him, said that 1/3 of the stomach should be reserved for food, 1/3 should be reserved for drink, and 1/3 for breathing or air. The Prophet ﷺ also mentioned that your body has a right over you, so it's important for us to take care of it. And there are two blessings that many people lose out on, which are free time for doing good and health, which oftentimes we neglect. And here's a chart here on the bottom that shows some of the foods that our Prophet, peace be upon him, liked to eat, which are documented in hadith extensively. Next, we'll kind of go over some basic diabetic foot pathophysiology and important considerations to be aware of in treating these patients. That diabetic foot is a very complex pathology that has many different components to it. The two most common are going to be peripheral neuropathy and peripheral arterial disease. When patients have high blood sugar levels, as they do in diabetes, that can lead to damage of the nerves, especially the smaller nerves which are present in the feet, as well as the blood vessels. And peripheral neuropathy in turn reduces sensation in the feet, which makes it difficult for people to detect injuries or wounds. And patients that have injury to the microvasculature in the foot often have a more difficult time to heal wounds when they do develop. And when they're both combined, these factors both increase the risk of foot ulcerations, infections, and other complications that can have significant morbidities down the road. And here are the subtopics of what we'll be going over on this talk on diabetic pathophysiology. So glycation is something I wanted to mention because it pertains to our field specifically in podiatry and foot and ankle surgery. So glycation occurs when there's excess glucose in the bloodstream, and this glucose attaches to proteins and lipids without the involvement of enzymes to break it down. So therefore, it develops these molecules called advanced glycation end products. So the mechanism is when the blood glucose is elevated, the glucose binds to proteins and lipids, which are not broken down by enzymes. Therefore, it forms these advanced glycation end products, which impairs protein function, causes tissue damage and inflammation, and causes cross-linking of tissues. And the accumulation of these advanced glycation end products contribute to several macrovascular and microvascular complications that can be managed by controlling your blood sugar levels through appropriate diabetes management strategies. More specifically, seeing the effects of glycation on the Achilles tendon. So glycation can affect the collagen fibers, which impairs the ability to withstand mechanical stress, leading to tendon dysfunction and contraction. Where it's most exemplified in the body is the Achilles tendon, which is the strongest tendon of the body, which connects the calf muscles to the heel bone and functions in moving our foot and ankle up and down. So the Achilles tendon is primarily composed of collagen. So when glycation occurs in the Achilles tendon, it results in increased stiffness, alters its mechanical properties, and reduce its flexibility, leading to contracture and the ankle to be pointed down in a downward position, leading to a condition called Equinus. So what exactly is Equinus? So Equinus specifically is insufficient ankle dorsiflexion or upward motion of the ankle during the normal gait or normal walking cycle, which leads to abnormal lower extremity compensation, which affects biomechanics. There's different components of Equinus, and it also significantly increases the risk of diabetic foot ulcers in patients with diabetes. And there's a specific study that kind of shows how Equinus is related to all foot deformities and can accentuate patients developing foot ulcers, because if the Achilles tendon is contracted, you're having an increased load in your forefoot or the balls of the foot where you have more bony prominences. And in patients with diabetes and reduced sensation, the patients don't feel this excess pressure when they're walking, and their skin can break down and develop into wounds, and they find out until it's too late. So equinus is often a root cause for a lot of the diabetic foot complications that we often encounter. And management of this condition is through strict adherence of stretching, physical therapy, splinting and bracing, and in more severe instances, surgical intervention to release some of the calf muscle components, or physically lengthen the Achilles tendon and then subsequently repair it in a lengthened position in order to maintain the proper foot alignment. And I'll pass it over now to Dr. Nasser to complete this lecture.
Assalamu alaikum. Inshallah, everybody can see my screen. For the sake of time, I'm going to just try and get through this a little bit quicker because I know there's supposed to be a question and answer period at the end. So as Dr. Qureshi mentioned, some of the microvascular complications with diabetes are retinopathy, which is in the eye, nephropathy, which is the kidney, and neuropathy, which can affect the nerves in the peripheral nervous system. And that's due to the exposure of prolonged high blood sugar levels, which damage the nerves. And that can lead to numbness, tingling, pain, and often starts as far as furthest from the heart, which is in the feet. And then it starts to continue in a stocking and glove distribution. So once it gets up to about the level of the knees, it can start in the hands. With regards to intrinsic musculature atrophy, what we see is hammer toes being caused by the atrophy of the intrinsic musculature, which leads to neuropathy, muscular imbalances, and then altered biomechanics. And just as Rafay said, that can lead to ulcers and a whole host of other problems. With regards to prevention and management strategies for hammer toes in individuals with diabetes, always maintaining a good blood sugar and controlling that is going to minimize the risks. Regular routine foot checks. We like to tell our patients morning and night, and then always wear white socks because sometimes they can't feel. So if they're wearing white socks and they step on something and there's any sort of drainage or bleeding, then they're able to identify that. Proper footwear, of course. So diabetics, depending on where you are in the country, almost everywhere, you can get a pair of diabetic shoes, which will offload your foot appropriately and ultimately help to reduce the chance of an ulcer down the road. Exercising and stretching routines are also going to be beneficial, and making sure you follow up with your podiatrist. So dermatologically speaking, there is poor wound healing, specifically due to what Dr. Qureshi was mentioning with the high blood sugars. And what that can lead to is neuropathy, as we spoke about, as well as xerosis, which is dry skin. And this can also lead to infections, diabetic dermopathy, which I'll get into, as well as fungal infections, which Dr. Khan was discussing, to try to avoid, sharing shoes or shahatas in the mosque. So with regards to dermopathy, it's actually seen in these images here. It's these small, round, oval-shaped patches on the shin of the skin, which are also called shin spots. And it's seen in about 30 to 50% of diabetics with long-standing diabetes. So typically they're asymptomatic and discovered incidentally and don't actually require any specific treatment, but they're believed to be related to long-term damage of the microvasculature secondary to the elevated blood glucose. So you can see a recurring theme is that the out of control sugars really leads to a whole host of problems. Xerosis is abnormal dryness of the skin, and it's actually seen to be one of the first indicators of undiagnosed diabetes mellitus type 2. And the treatment for that is moisturization to treat the underlying cause. And it's important to note that when you moisturize these areas, even if they do come up towards the interdigital spaces or the areas between the toes, it's pertinent that you do not put that cream or that moisturizer in those areas, because that is a breeding ground for bacteria and for fungus, and you may get yourself into another issue. Immunosuppression is very commonly seen in diabetes, and that's the reason that the wound healing, the fact that they get a wound and then the wound healing is really the main reason we see so many diabetic wounds. And the reason for that is the impaired neutrophil function. So there's a slower response to migrate those immune cells to the area required, as well as reduced T cell function, which compromises the body's ability to combat the infection, as well as cell communication being altered. And that impairs the coordinated response necessary for an effective immune defense, which again prolongs their healing process. Diabetic complications, as we spoke about, neuropathy, as well as vascular disease, which restricts blood flow and nutrient supply to the immune cells. Diabetes may not affect all aspects of the immune system equally because inflammation can be heightened, chronicity of inflammation may slow the wound healing, and managing this diabetes through blood sugar control as well as a healthy lifestyle and adhering to the prescribed meds can help minimize not only immune suppression, but as well as reduce the infection risk. So as I mentioned briefly before, you want to make sure that you're inspecting your feet daily. You're practicing good hygiene and moisturize, but making sure not to go into the spaces between the toe or toes. Trim the nails carefully and appropriately, which I'll get into in the next slide. Wearing appropriate shoe gear, making sure to change socks and wear white socks, not black socks or dark socks. Protect your feet, regularly exercise, and avoid smoking. Smoking is a huge risk factor. So when we look at a diabetic and we do an examination on them, there's four main things, and this is with most podiatric exams anyways: vascular, musculoskeletal, neurological, and dermatological. So first we want to look at their blood supply. Do they have a good capillary refill time? Is there hair growth around the toes? Is there any swelling? And then when we look at their musculoskeletal system, how is the strength? Are there any imbalances, pressure points? Is their range of motion okay? Equinus, like Dr. Qureshi mentioned. And then neurologically speaking, we want to see, are they able to identify proprioception, as well as are they able to sense what we are doing? So we use something called a monofilament, which is a little small, almost like a fishing line. And essentially it allows us to determine if they can feel just the smallest little pinprick to determine if their light touch is intact, or if it's diminished, or if it's absent altogether. Dermatologically, we kind of already spoke about, what's the quality of the skin? Is there xerosis? Is there dryness? Is there a wound? Is there a callus? What's the situation there? So inspect your feet daily. If you need to use a mirror to check the bottom of your foot because you can't see the bottom of your foot, that's always a good option. It's important to practice good hygiene and to moisturize. And as I said, let's avoid between the toes. All right, cutting the nails. Although most people think, you're supposed to cut your nail rounded like your finger is, it's actually not the case. You want to cut it straight to avoid any ingrown nails or toenails, and avoid cutting them too short. And also you could see your podiatrist for this if this is too difficult for you. So again, wearing appropriate shoes, choosing something that's well fitted. As Dr. Khan mentioned, we don't want to break in a brand new pair of sneakers when we're going to do a 40-mile walk. So make sure we break in the shoes appropriately and we get them fitted appropriately, as well as wide enough. And too commonly, I think we see that they are too tight, whether that be in the toe box in the front or even around the midfoot area. And that leads to friction and ultimately a wound down the line. As I said, smoking is a huge risk factor, and it's an independent risk factor for diabetic neuropathy, commonly 30 to 40% higher risk of diabetes than non-smokers. So smokers have, 30 to 40% higher risk of diabetes than non-smokers. So tips for preventing complications. We want to make sure we manage our blood sugar levels to an acceptable level. Check up with your primary care, your endocrinologist, whatever other doctors is necessary in your situation. Maintaining a healthy weight, not getting obese like we were discussing in the other lectures. Regular exercise, which ties into the last point, and management of your diabetes and self-education. So remember, it's essential to involve your healthcare provider, particularly a podiatrist or foot specialist in your diabetic foot care, as they can provide personalized advice, evaluate your foot health, and address any concerns or complications you may have. And below are our references. And sorry, I went a minute over. I apologize, but thank you all very much for joining us. Assalamu alaikum wa rahmatullahi wa barakatuh.
Thank you so much, Dr. Khan, Dr. Qureshi, and Dr. Nasser. If you could spare us maybe an extra 5 minutes or so, we do have a couple of questions. This was a very eye-opening presentation. I don't think I'm alone in saying that I really appreciate the research studies that were shared. It was very interesting, the connection with pathological issues and Islamic rituals and Muslim majority populations. Also was understanding the foot care for diabetics from a podiatric perspective. So we have a couple of questions, one of which is a question about foot odor. A common unpleasant experience in the masjid is foot odor. Any recommendations on how to combat this?
Okay, I can start with this, and you guys can chime in. So foot odor, I mean, some people have a condition called hyperhidrosis where they just sweat a lot, and like, we see these people in our clinics all the time in our offices, and we just tell them like, hey, just rub some deodorant on it, right? There's a thing called dry sol. You can, put it on your foot and you won't be sweating as much, right? So it's typically related to sweat for the most part. Some people are coming to the masjid, especially like, for Jummah, they're coming like between like their morning and afternoon shift, for example, and their feet are kind of sweaty. So it's more of just controlling the sweating more so than anything else. And, if nothing else, I mean, I even tell patients just put some deodorant, the one that you would use for your armpit, like put some deodorant and antiperspirant on the bottom of the foot, and that oftentimes works. So I don't know if you guys have anything else to add.
Just briefly, talc powder, TALC, or Domesboro soaks, and I can write this so you guys can see it after, are commonly used in my area.
Thank you.
And just changing socks and shoe gear regularly, I think, is very important as well to kind of combat foot odor, in addition to what Dr. Khan and Nasser mentioned.
Gotcha. The next question is on your thoughts on halal nail polish. Is it actually water permeable? And then just generally with nail polish, is this something which is deemed safe for just nail care overall?
A halal nail polish, I mean, I have talked to a few sisters about this. Obviously, it's not something I'm using, but I've heard mixed things about it. But for the most part, if there is some research or literature backing up that water does penetrate through it, then you kind of have to trust the research, right? But obviously, if you want to play it safe and avoid it, I mean, that's understandable too. In terms of for nail care, if someone has a fungal infection, for example, I typically tell them not to use nail polish, especially if they're using topical antifungals, because definitely it's going to affect the permeability of that medication. I don't know if that answers the question, but my best I could do.
No, I think you did. And I think the only thing that I would add, just where my mind goes, is that when I hear about nail polish, I think about nail salons, and I would kind of avoid those at all costs, because too frequently we see somebody who's went to a nail salon and then shows up with nail fungus down the line. So I know that doesn't answer the question directly, but I did want to mention that.
Yeah, thank you. There was actually a question following up about your thoughts on pedicures in general, but also was specific for those who do deal with diabetes. Is that something that puts them at a greater risk of complications?
Yeah, I think with diabetes, honestly, it increases the rate of complications for a lot of conditions. I think even with nails specifically, diabetes can affect the small blood vessels and the small nerves going to the very tips of the toes, and that's what really supplies the health and nutrition to the nails. So oftentimes with diabetes, you'll have patients that have just thicker nails in general. even if it may not be fungus, it may just be a thick nail, and that's due to the chronic damage and injury that those nerves and blood vessels have undergone just through elevated blood glucose.
Thank you. Kind of going along with diabetes as well, and we have several medical specialists who will be listening to the recording who may be interested in your thoughts on this, that for those with diabetes, foot pathology is a major complication, but oftentimes it's not often valued amongst the patient population. What advice would you give to an endocrinologist or a PCP physician on bringing this awareness to their patients with diabetes? Any advice you would offer them in regards to the foot pathology that their patients may experience?
Jacob, you can take this one. You can start with it. I'll add something.
Certainly. Yeah, I mean, not to scare them, but I think unfortunately, too commonly, we need to educate them about kind of the worst possible things that can happen down the line. So talking about these diseases like Charcot and other situations where, haram, people end up getting amputations because they had diabetes for so long, it was managed poorly, and they never sought any counsel or medical attention for their feet until it was too late. I think talking about those types of situations to try to educate the population so that they don't get the Charcot, they don't get the infections, and instead they're coming for preventative care. They have a callus or a wart or something simple that is very easily treatable and not going to cause any issues down the line, even if they do have comorbidities.
Yes, I think Dr. Nasser hit that on the spot. I mean, the only thing I would add is, like Dr. Nasser mentioned, the calluses, right? So even just talking to the primary care physician about what calluses actually are, right? It's a pressure point, right? It's a risk factor for becoming an ulceration, right? And an ulceration can ultimately become what? An amputation, right? So then one statistic that I think it's been kind of recycled over and over again in the podiatry literature is that the 5-year mortality rate for a below knee amputation is 50%, right? That's higher than a lot of cancers, right? So when you start to kind of talk to them that way, it's like, oh, wow, that's 5-year mortality, 50%. That's really high. But it's like, it just starts with the callus, it starts with the wrong shoes. It starts with not seeing your foot doctor once a year, right? So I think that's kind of how I would approach it in addition to what Dr. Nasser just said. Absolutely.
Yeah, definitely. And a big takeaway is when you think about the complications of diabetes and the referrals that you see to nephrology or ophthalmology, but also podiatry is just as important. It's equalized and probably one of the first signs of a complication of diabetes, because as you mentioned, it's something so small can lead to something so severe down the line. Another question we had, it kind of aligns with, I guess, with footwear. This is just a general question, not just for those with diabetes, but there's been speculation about Crocs have a negative reputation for being considered poor footwear, but they're very on trend. What are your thoughts and recommendations on footwear, for example, high heels or even with Crocs?
Crocs, yeah, I mean, everything kind of just depends on what your foot type is, right? I mean, I don't think there's one magic shoe for everybody, right? Everyone has a different foot type. Some people have flat feet, some people have high arches. For Crocs specifically, I like to recommend them for like around the house at least. Some people are wearing slippers or they're barefoot and they have a bunch of calluses, right? And the Crocs, sometimes some of them have a good arch support, right? So me, for example, I wear Crocs around the house, right? I'm not getting paid to say this, but I'm really comfortable in them and I have flat feet, right? My wife has the same issue, right? And we love the Crocs, right? But just for around the house, right? But I wouldn't wear this, out and about everywhere, not for the stylistic reasons, but just for instability, right? You do have a little bit of instability. It's not really capturing your heel that much. Your feet are kind of floating around. So there are some issues with it. So I really think with Crocs, it depends on how you're using it. That's just my opinion. And for high heels, that's like a totally different topic. Maybe one of you guys can chime in on that one.
Rafay's a big fan of high heels, but I'm actually not. Can lead to all sorts of issues as well. You're putting a lot of stress on your plantar fascia. You're putting a ton of pressure on your first MP joint, your first metatarsophalangeal joint. And frequently what ends up happening is that toe starts to jam and leads to a procedure eventually needing to happen, whether it's fusing that big toe or removing parts of bone and putting screws in there. It essentially just jams up that joint, and that's where about 50% of your motion comes from, through the toes. So something to consider. Now, if it's once in a while, right, you have a wedding or you have something that you're doing it for, I mean, to each their own. You know, you're gonna look nice. You got to do what you got to do. But every day wearing that is definitely going to cause a problem.
I'm sure with your profession, people pay attention a lot to the footwear you choose to wear and use it as a source of, guidance. I also really appreciated the notes in regards to shoes in pilgrimage. As you mentioned, males are required to expose certain areas of their feet. So it was interesting, your perspective on options of foot care with that. One last question, and this is for our recording so that our audience can get a chance to know you guys on a professional level, is what are your particular interests within your field and the most common foot disorders that you typically see within your profession, in case someone wants to reach out to you in the future, whether it's a fellow physician or a patient or someone in our general audience that would like to seek out. So I'll let each of you get an opportunity to answer this.
Okay, I'll start. So again, I'm working at a federally qualified health center in Buffalo, New York. So we take people regardless of their insurance, and I honestly see a whole gambit of things. I see a whole spectrum of things, but my particular interests are in wound care, and limb salvage for people that have life-threatening or limb-threatening infections and trying to salvage either their limb or save their life. And elective surgery in the foot, that's kind of a lot of what I'm doing. Neuromas, bunions, hammer toes, soft tissue masses, minor fractures, things like that. It's mostly outpatient stuff. But that's more of what I'm doing right now. Obviously, I'm actually graduated from residency 2 years ago, finished fellowship 1 year ago. So my practice is still evolving a little bit, I guess you could say, but that's kind of what I'm doing right now. So.
Yeah, Dr. Nasser and I, we just finished residency, and Dr. Nasser's in fellowship right now. I'm just starting my practice here, so I don't have a particular patient population that I'm seeing frequently just yet. But I think just in the early stages, in podiatrists in general, I think we see a lot of flat feet, a lot of heel pain, plantar fasciitis, a lot of sports medicine. And with me, I mean, I'm going to be doing hospital work as well. So it's a lot of different things, a lot of different pathologies. We see people that are very, very sick, and that's the patients that I take care of at the hospital, that are very limb-threatening conditions. And we see people that are, very, very high demand, and they want perfection in every single thing that they're seeking, whether it be surgically or non-surgically. So I think the areas of focus that I think I'm more inclined to build my practice towards is kind of a mixture of elective surgery and reconstructive surgery, as well as limb salvage in the hospital settings.
I think they both nailed it. We're kind of all in a similar boat. And as Dr. Qureshi said, I am doing my fellowship in wound care and limb salvage right now. So that is my particular interest. Never thought it would be, especially after my first day in the podiatry clinic, but it's funny how things change. And you know what? There's something very rewarding about seeing a wound come to fruition and completion and heal. So I think saving a limb is like saving a life, and it's very rewarding. So I think that's all.
Thank you so much. We'll go ahead and conclude this webinar for tonight. I would like to thank Dr. Khan, Dr. Nasser, and Dr. Qureshi for taking the time. All the best to you as you are developing your practice. On behalf of IMANA, we would be happy to have you back to discuss another podiatric topic if you are available and interested. For those who are listening, please reach out to IMANA Education on what topic you would like for them to discuss next, or to delve into further. And with that, we'll go ahead and close for the evening. Jazakallah khair, and Assalamu alaikum wa rahmatullahi wa barakatuh.